Hello, welcome everyone.
Hello. Wow, look at the range of everybody where they're coming in from. Minnesota. I don't think we've had somebody. Minnesota isn't being well represented. Jill, you need to let them know.
We got our favorite, Sylvia from Texas. Hey, Sylvia.
Yeah, she sent me a note and said she was in the background.
We got Jill, Amaryllis, Chandra, Anne, Cynthia, Linda.
Sandra,
I had to make a graphic for a meeting for our interns, which are all women. We are a mighty army of women. And it kept giving me all these men in suits. Said, no, this is a female-dominated profession. But do we have any men out there? Let us know.
So this is Sandra's first time.
Oh, welcome.
Yeah.
Welcome, welcome. So as we were reviewing our slides, we have we had two topics. Let me get to that. I think, am I in the right spot? Nope. There we go. I was supposed to be doing the perineum problem, but I have a problem with the perineum problem, so I'm not going to be able to present it tonight. But Alicia said that's good because hers is very meaty and she didn't know how she was going to do it in half the time. So we're just going to do the one topic on the heart attack codes, and then I'll try and do the other one on another webinar. So we're going to focus on the heart attack ones. So what time is it? Are we at top of the hour?
Yeah, top of the hour, minute past.
All right, top of the hour. So let me see, did I have any? Yeah, we just wanted to give a shout out to our interns, Kristen and Tatiana, who prepared the slides tonight. We're going to be going over Kristen's tonight, and Tatiana will have to get next time. So I'm going to, do you want to drive the slide for yourself?
Sure. Let me just, I'm going to put mine in presentation mode real quick, and then you tell me when it's time to. You ready for me to share?
You just have to click to share your, on the bottom, present or invite, to pull up the slide deck. You know what I mean, Alicia?
Yep.
Oh, okay.
I was doing it.
There you go. You were smiling, but I didn't know.
My brain, it's hard to smile and think at the same time sometimes. My mother used to joke, you can't chew gum and talk at the same time.
That's right.
Right, guys. This is one of my favorite topics. And it's part of the guidelines. So if you're preparing to test, this is something that you will be tested on. In addition, it's real world. You're going to see this come across your desk. So it's important that not only do you understand heart attack codes, that's the layman's term, but we would call them STEMIs, non-STEMIs, and there's some other diagnoses that are involved and surround those that verbiage that you want to familiarize yourself with. But in addition, I'm going to give you some documentation tips. The reason this is so important is because our role is not just translating the documentation for the providers and the clinicians. It is also to make sure that they understand the documentation that needs to be made for specificity, so that we can get proper statistics as well as reimbursement involved. So again, this is very common, and therefore it needs to be in your knowledge belt, where you feel incredibly uncomfortable in doing these. Now, one of the things that we need to know about is the anatomy. So I'm going to talk about that as well. One of the things we've stressed for a very long time, well, from the beginning at CCO, is that there are certain areas of the anatomy that you need to have memorized, and other areas that you just have to be familiar with. but the anatomy of the heart is something you need to have memorized. And we'll tell you when we're doing our education. You'll see, you'll go back and look at our videos, the webinars and everything, and we'll say, you know, you need to memorize this, or no, you just need to be aware of this. With the heart and myocardial infarctions, the anatomy is incredibly important. And so is the disease process, the pathophysiology of a myocardial infarction. The first thing I want to tell you real quickly is that an infarction is a blockage. Okay, myocardial is heart muscle. So cardial is heart, myo means muscle. With an acute MI, and that's how you'll see it abbreviated in the documentation a lot, is that's different than an old MI, and we'll go over that in a moment. Some key facts that you need to know is that when you look these up in the tabular, it'll be under I-2-1. That is going to be your acute MIs. Now, when you go and look this up in the index, you're going to look under infarction, because that's what has happened. There's a blockage. Where's the blockage at? It's in the heart. What is that called? The heart muscle, myocardial. So that'll be the second term you look up. It is absolutely important that the documentation is clear. When a person comes in and they're having an acute MI, the documentation is going to be very specific. So you have to understand that. You may end up looking at lots of different notes, depending, but by the time the cardiologist has gotten in there, it's going to be well documented. There's two major types, and they can be acute or chronic, but we're talking about acute. The two are STEMIs and non-STEMIs. So I'll break that term down in just a moment, but let's really quickly look at the graphic. So when we're trying to figure out if a patient is having a STEMI or a non-STEMI, that's determined with an ECG or EKG. So they will do an EKG right away when a person's having chest pain. There's a protocol that goes in place, and one of the first things they start doing is popping those leads on a person. Now, if they come in from an ambulance service, they'll already have the leads on them, and they'll already have a tape that we use. You know, now they don't really print out tapes like they used to, but it'll digitally show the doctor in the ER upon transport what's going on with the patient. Now, for a STEMI, you're going to have the code ranges of I to 1.0 through 3, and then a non-STEMI is I to 1.4. Now, there's a reason that these are separated, because they're two different types of infarctions, two different types of blockages. It's really critical that you understand the difference between a STEMI and a non-STEMI, and you never assume that it's one or the other without the documentation. And they will write STEMI and NSTEMI. So those two abbreviations you need to have memorized. And by the time we get done with this education, you'll have it under your belt. So the way that you code this from the beginning is from that evidence from the EKG or the ECG. It means the same thing. We don't code from the imaging. However, the clinician and the physician will look at the imaging from the EKG, and they will give a diagnosis. Now, something I'll just impart to you from experience is that most cardiologists do not feel that this imaging, the readings are accurate. So they very seldom will go by what the diagnosis on the imaging is. So if you were to like pull the tape, you know, and they rip it off and they look at it, and sometimes they'll make a few little marks. But now that it's electronic, it'll pop up on the screen and it'll have its rendering thoughts. Okay. And most cardiologists don't like that. However, don't assume that what that states, the little EKG strip or reading, what it states is accurate. Okay. Because we do not code from that. We have to code from the documentation by the clinician. That being said, let's look at 3 major things that could be a diagnosis for a possible MI. We're going to, again, look at the STEMIs, the non-STEMIs, and also there's unstable angina. Now, some people pronounce it angina, other people pronounce it angina. Both of them are correct. I just learned it as angina, so that's the way I say it. They're 3 distinctive diagnoses. Just so you'll know, this is what they look like. The waves look like on the findings. You don't have to have that memorized, again, because you can't code from that. But let me tell you some verbiage that you're going to hear talked about or that you'll see documented. So what we're looking at is the ST segment and that elevation. So when you look at the comparison, the one for angina, that is really what your rhythm should look like. But notice the STEMI. So the ST segment, which again, we did a video some time ago explaining what all of this was. You can go back and look at that. But see how we have we have a peak, and then it kind of looks like a ski slope. That's the ST segment, and it's telling you that there is a full blockage, right? That right there is a STEMI. It's a full blockage. The non-STEMI, notice that instead of going up and being a ski slope, we have like a little gully, right? So that's an ST depression. So the T wave is inverted. With a when you have unstable angina, that's chest pain, and that's not a blockage. We'll talk about more of that in a little bit. Now, there is a chemical response to the body, the heart being stressed and having a blockage, and that's a troponin. And they do this lab immediately when they think that a person might be having a heart attack, because it will elevate. Now, there's other things that will make this elevate, stresses and stuff. A person coming out of surgery or trauma to the heart can do that, but it will always go back. The heart gets stressed, panics, that chemical shoots up in the air to try to correct it, and then it stabilizes. So it's an elevated troponin. You'll see that documented and talked about a lot. With a STEMI and non-STEMI, that will happen. That chemical goes up. But if it's anything else, it doesn't. It may go up temporary, but it won't stay elevated. So they'll do repeats, and they'll say, no, we're confident this wasn't a heart attack. This was chest pain or something else. The next thing is the pathophysiology aspect. And this is what you've got to understand, because the guidelines are based on this, and it'll make sense if you do. Whenever you have a STEMI heart attack, there is a complete blockage of a vessel. So we'll show you some images, but that blood vessel has got a blockage, whether it's a clot or plaque, it doesn't matter what it is. Blood is not getting through anymore, a complete plug of the line. With a non-STEMI, that's different. We have a partial blockage, so a little bit of blood still getting through, or we have a little bit of blood, then it blocks complete, then it goes to STEMI, and then it goes to non-STEMI. A little bit more blood gets past the blockage, which is called transient. Okay. And they'll call that a sometimes transient coronary artery occlusion, or a subendocardial ischemia. You'll see those documented. With angina, unstable angina, it could still be an occlusion. It could be partial or transient, but the difference is there's no death of tissue, no death of heart tissue. When you have a STEMI or a non-STEMI, there's so little blood or no blood getting through to the heart muscle that it starts to die. It becomes necrotic. Okay. And once heart muscle dies, there's no coming back from that point. Okay. So that's why time is really important. Last, let's look at the clinical presentation. When a person has a STEMI, they're going to have severe persistent chest pain and they're in acute distress. They think they're going to die and they tell you, I'm dying. Another thing that they'll tell you, one of the things we learned in the ER, they will usually clamp their hands into a fist and they'll hit their chest. I'm dying. The Empire State Building is on my chest. There's a gorilla sitting on my chest. And it's a severe pressure. Now, with a non-STEMI, that is still, chest pain. It's severe. They may even have that impending doom type feeling, but it's not as severe as a STEMI, because with a STEMI, the heart is dying. It's going to stop. Whereas a non-STEMI, there's a little bit of blood getting through a little bit, but still there's a panic mode with this patient and they're showing all kinds of signs. Then with an unstable angina, that's chest pain, but what's different is that it is usually they say, you hear the old adage, they went out and shoveled snow and they got chest pain, but when they went in and sat down, they felt better. Okay, with unstable angina, it doesn't get better. They go back, they sit down, they relax, and they still have that chest pain. And it doesn't matter if they just do a little bit of exertion or not. And it comes and goes, and it can be really frequent. It can be real severe, and then it waxes and wanes. STEMIs and non-STEMIs don't do that. Okay. So those are just some documentation things that you're going to see in presentation, and it's important that you understand that. Now let's get a visual effect. So with a STEMI, we have a complete blockage of blood getting through that vessel, and the troponin will elevate, and it's severe chest pain. Whereas with the non-STEMI, it's less of a blockage, and it can block and let loose, let blood through, and block and let blood through. Again, you still have the lab values that are elevated in the chest pain. With angina or unstable angina, there's narrowing and everything, but blood's getting through. But this is the telltale sign that, hey, something is going to happen in the future. We got a problem. There's a blockage, and we need to investigate. And that blood level, that will be very reassuring. Whenever they have this, they'll go and usually cath them and say, let's see what's going on. Again, imaging is really, really important. And this anatomy of the heart is going to be advantageous to you. We're looking at a clot or a thrombus. And when you see this, if you see where it says the infarcted myocardium, that part that is, which I don't know if you can see my cursor when I do this. Yeah, you can. So this part right here is, they're saying, is being affected. So it's getting no blood flow, and then that starts to die and break down and become necrotic. Whereas this is the healthy myocardium, and it's supposed to look like this. So where there's a clot, no blood gets through, it starts to die, and we have pain. The characteristics for those we've already gone through, but keep in mind for an acute STEMI, full blockage, The code is going to be I21.0 through I21.3. And this is called a STEMI or ST elevation when they do the ECG or EKG. Full blockage, and the severity means that this is life-threatening. It's a medical emergency, and this patient will be in critical care. So you could have some critical care codes dropping because of that as well. So common locations that these blockages happen, we have the anterior wall, and the way that's documented, they'll say left main or LAD. Inferior wall, which is the right coronary. Other sites, the circumflex, and then it could be unspecified because they haven't been able to see in the imaging yet. But where the blockage occurs in the heart is incredibly important because we have codes to specify that. And the reason they want to know is multi-factor. One is, if we're going to have to go in and do a bypass, are we going to have to do multiple bypasses? Or where are we going to have to go get a saphenous vein? If it's on the back of the wall of the heart, then we're going to grab a saphenous vein from the leg to do our to open up from the blockage, or they may take the mammary vessel if it's on the front part of the heart. So all of that plays a part. Also, we just know statistically, again, that's why you need to know the anatomy of the heart. Now, with a non-STEMI, a little different, I21.4, and they will say, non-STEMI or elevated troponin without STEMI elevation. Sometimes you'll see that, but most of the time they just say non-STEMI. It's a partial blockage, and with this, there is no site-specific coding. Unlike a STEMI, means we have death of tissue. We got to get in there right away to take care of it. Non-STEMI also very emergent. However, it's coming and going, so blood's getting through a little bit. Now, with the lab findings, you're going to absolutely see that which part of the heart is being affected because of the ECG, but when they do that lab troponin, they'll be able to confirm that it's a STEMI. Excuse me, a non-STEMI. And this is kind of a layout. This is kind of unique how, like if you were in med school or cardiac nurse, you would learn this information. So that was kind of interesting, have that added in there. Now, what are the key differences? You got to know this. When we have a STEMI, we have an ST elevation, and then the non-STEMI, there is no ST elevation. So again, we have a ski slope or we have a gully. The blockage is either complete or partial. Put a pin in that because we're going to come back to that. Location, STEMIs, location is pertinent and we can code for the location. With a non-STEMI, we don't. And last, severity. More severe with a STEMI, less severe with a non-STEMI, but it's still critical. Okay, so a non-STEMI, why that's incredibly important to understand is because we can be a non-STEMI, not a complete blockage, and then turn into a STEMI, complete blockage, while they're sitting there in the ER. At any time that can happen. And that changes the way we code, because the most severe always trumps the way we code. We code to the most severe at all times, even if it reverts back to a non-STEMI. It still got to the point of a STEMI, complete blockage, opened up, a little bit of blood got through, it reverted to a non-STEMI, and then it went back to a STEMI. It's still going to be coded as a STEMI. If it was a STEMI, went to a non-STEMI, it's coded as a STEMI. If it's a non-STEMI goes to a STEMI, we code as a STEMI. If it's a STEMI, non-STEMI, STEMI, we code as a STEMI. Okay, so the only time that you code a non-STEMI is when it maintains that, right? So think of it as a severity ladder. Once you hit that next rung of a STEMI, you take that step up in severity, you don't code the to 1.4. Now you'll see that documented back and forth. And if you don't understand that process, you're going to get confused and you're going to code it incorrectly. And that's why this is a classic exam question for your credentials. And it's on a lot of different credentials. It's a basic guideline that you need to know. Now let's look at the codes a little more in depth. Again, when we're doing a STEMI, we want specificity as to where the blockage is. So therefore, we have codes for that. Let's start with the anterior wall. We know we're using I21, but the next character is going to give us the location. So if it's the anterior wall, which is the back of the heart, right? Yeah, anterior. Then, no, posterior. Posterior is the back of the wall. Anterior is the front. Anyway, so that means we have two major vessels to think about when it's anterior wall. We have the left main coronary artery and the left anterior descending coronary artery, or we don't know for sure. Okay. So, or there's other vessels in there, but the two most common ones that get occluded are the left main and the left anterior descending. That being said, it will be documented, and it'll be 0.01 if it's left main coronary. If it's left anterior descending, it's 0.02. Why is understanding the anatomy and the vessels of the heart so important? This is exactly why. And you can find this anywhere on the internet now to memorize it. The other vessels, at this point, there are not codes for them. Will there be in the future? Absolutely. But if it doesn't say left main coronary artery or left anterior descending coronary artery, but it says anterior wall, then you're going to use 0.09. If we have the inferior wall, we have two choices. Again, right coronary artery and other coronary artery of the inferior wall. If we have other sites, and this means that it's not the anterior wall, it's not the inferior wall, it's somewhere else in the heart, then you have two choices, and that includes the left circumference coronary artery or other sites. So the key here, guys, is if it gives you specificity as to where it's at, if it says left main coronary, then you know that's the anterior wall. If it says left anterior descending, anterior wall. If it says right coronary, it's inferior wall. If it says circumference, it's other sites. It'll be a 2. See where I'm going here? Now, what you should do is you should make yourself notes here. And if you're part of our club or you have access to the academy, you will be able to see this and you'll be able to make notes and everything. But this is really, really critical for you to understand how it's divided up. And that's why we push so hard for you to understand the anatomy, and you got to get that verbiage under your belt. So now we're going to look at the non-STEMI. It's a lot easier to do a non-STEMI because it's I to 1.4, right? It's and then you're going to assign the code with highest specificity location based for STEMI if it goes from a non-STEMI to a STEMI. Okay, we're still going to code for the STEMI. And here again, it just kind of shows you what normal looks like. We have a little hill, and this is that STEMI where you have it dips down. The T wave dips down, the ST wave dips down. You have a little gully. But if you have a STEMI, it's like I think of it as a ski slope. You know, you have a mountain. There's a little bitty hill. That's what we should have. The guidelines are Non-STEMIs that evolve into a STEMI, you code the STEMI. STEMI that converts to a non-STEMI, and it's due to thrombolytics, meaning they're going to shoot you full of blood thinners, and then that blood will get back through. It'll open it up a little bit. It's still a STEMI. Also, classic test question within 4 weeks from the time the time the patient's had a STEMI or non-STEMI, and it will continue to be coded I-21. After that 4-week window, then it's coded as an old MI, okay? And that's I-25.2. But it's got to be anything between the time and 4 weeks is still always going to be coded I-21. Doesn't matter where they're at and who sees them. Now, after that 4-week window, then it becomes an I-25.2. However, what can happen, and it very often happens, is in that 4-week period, if a person has an acute MI, they are like, I don't know, like 75% chances are they're going to have a repeat, a subsequent MI. There's another code for that. That's why they keep that 4-week window in there. It's very important. And that's a test question. That 4 weeks. Remember, MIs, 4 weeks. You have STEMIs, non-STEMIs, 4-week window, old MI, which is the I-25.2 moving forward. Now, if a person has an unspecified acute MI and you don't know anything about it, that's an I-21.9. Okay, you're not going to have that very long because this is an emergent scenario, and they're going to identify it. They'll have cardiology and the specialists in there to identify it ASAP. But again, if you don't know, we need that code while they're still doing testing. Let's look at some of the documentation again. If we see this in writing, I think that it will help you. So when we talk to our physicians and your NPs, your PAs, and stuff, when they're learning to document this, we need to make sure they specifically state, was this a STEMI or non-STEMI? Very seldom are you going to have this not being documented properly if you're in an institution, and that's usually what you are in when, a hospital of some type, when this happens. The anatomical location, we need to know anterior, posterior, and inferior. So anterior is the top of the heart, inferior is the bottom of the heart, posterior is behind the heart. Okay, so again, make sure you understand that. Timing. Acute MI means they're having it now for the 4-week window, they're still acute. Then if they have another MI in the 4-week window, that's called a subsequent MI. I'm not going to give you the codes for that. But after the 4-week window, it's called an old MI. The therapies, they give them blood thinners, which is called thrombolytics, PCI, and there's some other interventions. They will do KGs, ECGs, and they'll do the lab findings because we're looking for the troponin levels. Now, always avoid making assumptions. Never use an acute coronary syndrome, which is ACS, without a specific diagnosis, because acute coronary syndrome is different than an acute MI. Let's look at a couple cases here. Now, I think you're going to enjoy this. The first one, let's break this down. The patient has chest pain and an ST elevation. So they do the tape. The provider documents acute anterior wall STEMI. So the first thing we're going to do is we're going to identify the type. It's a STEMI. That should just leap off of the page at you. patients having a STEMI. What does that mean? Complete blockage, right? There is now death of the tissue, the heart tissue that has begun. They will have to do a bypass. They will, start pumping them with the drugs, trying to see if they can turn it into a non-STEMI or flush through that blockage. But yeah, that's a problem. The next step, it's a STEMI now, complete blockage. Where's it located? Anterior wall. And then we need to know the code, I21.09. Well, why is it a 0.09? Because I21.09 is a STEMI of the myocardial infarction involving other coronary artery of anterior wall. And I am just, no, it's not. Yes, it is. 09. I'm sorry. Let me go back. I'm looking at my notes here. Yeah, there it is. So when I look at it, I21.0 STEMI of anterior wall, but which vessel? Is it the coronary artery left, or is it other coronary artery? And if it's other, which they didn't tell us which one, they didn't say that it was the left anterior descending artery, so then it's a 0.09. Now, the way this is what is confusing, because it even tripped me up. So I21.09 looks a whole lot like I21.9, but I21.9 is unspecified STEMI. Okay, so you got to pay attention. You can't go too fast. All right, let's look at the next case. Case 2. All right, so now we have patients admitted with chest pain and elevated troponins. That lab level went up. They did the imaging and shows no ST elevation. So they got a gully instead of a ski slope. Provider documents acute non-STEMI. A little bit of blood's getting through. So first, we identify the type. It's a non-STEMI. Then we identify the location. Well, they didn't give us a location because a non-STEMI doesn't give you location. Remember, STEMIs give you location. So we assign the code I21.4, and I'm looking here. So that would be an AMI, acute myocardial infarction, non-STEMI, I21.4, because the code description's much smaller. I would encourage you guys to do some education for yourself, do research. Go research the troponin. I think that's an interesting drug. All right, now we're going to go and look at a third case. Patient with an acute MI involving the right coronary artery. Provider documents inferior STEMI involving RCA. Now that's different. So what did we do first? The very first step, we identify what type. It's a STEMI, full blockage. Location, right coronary artery, inferior wall. And then the code is going to be I21.11. I'm just looking at my encoder over here and find a code, which is STEMI, myocardial infarction involving right coronary artery. Now, I noticed that Sandra had asked the question, wait, I don't see posterior. What is the code? Okay, well, let's go look at it. So what we would do, and I'm going to show, let's see if I can show you this real quick. I don't think it's going to show up if I move my screen. Nope, I did this.
If you're looking at a different tab, Alicia, you should be able to just click share this tab instead.
Okay.
You know what I mean? You're looking at Find a Code?
Yes, but I shared my screen and not tab.
Well, then you should be able to show whatever's on your screen. Okay, well.
I'll just hit it again. Wait, let me move it here. I think it's because I'm in presentation mode. Maybe. Let's.
Nice comment. This is great. Thank you. Alicia's a very good presenter.
Well, I love this stuff. I mean, this is one of my favorite things to talk about. There we go. All right. So what Find a Code started doing was they gave us this little cheat sheet. Now my screen is a little bit smaller here. Let's see. No, I can't get it on there. Let's hide that. All right. So you wanted to see posterior wall. So let's just assume that one, we're looking at the manual itself, and we've already found I2 1.9. We know that's the basic heart attack. We don't know any more information. So we want to look over here. I don't know if that's going to give me. We can either scroll up or down, right, and try to find it, or let's go ahead and go to the index. So we're going to look at what did I tell you? I told you infarction. Oh, wait, I didn't say index. ICD. I went index. Sorry about that. I'm going from a big screen to a little one. Okay, infarction. Infarct. So now there can be infarctions, which just means blockage, all over the body, all different body systems and stuff like that. So we want cardiac or heart. Let's see if you can look up heart. Yeah, it has heart. Or we could do cardiac. Let's just do heart. Let's go basic. So then it tells you, oh, go see myocardium. Well, which heart would it do that? So now it's telling you, oh, you need to go to I21s. Yes, we do. But is it going to let me? It's going to take me. Oh, look, with stated duration of 4 weeks or less, because I told you that's a basic guideline. So let's go there. Man, I wanted it to bring me to the book view. Why is it doing this on the side? I think I can tell it to stop. I'm going to look this full index side. Why is it doing that, Laureen?
I think you can turn that off. Well, I know you can. I just don't remember how either.
I remember it told me, do you want this view or not? Let's see if settings does it.
I like that view too, though. I like to have the book view over on the side.
When you have it on the big screen, you can see it, but on my little screen, I can't.
Let's see.
Oh, this is something that's interesting too, guys. So one of the things that they do with Find a Code.
In the upper right-hand corner, it says switch to pop-up version. You might have to scroll to the right to see it.
Let me put it on my other screen here, and then I'll.
Okay.
There, I see it.
That book view is very nice with Find a Code because, with encoders online, you lose the context.
Yes.
Of where you are on the page. So having that book view kind of keeps you as if you literally were opening up the book and you can see the context. So with Find a Code, you can either just pop it up and go look at it or have it always open on the right.
Mm-hmm. This is another thing we talked about, that syndrome. This is another one.
Don't your desktop anymore.
Oh, sorry. I moved screens again.
I am needed.
Notice here, this coronary microvascular dysfunction. That is, don't get those confused. That when a person is having a STEMI and a non-STEMI, it's the major vessels going into the heart that wrap around the heart. And that's why they're telling you anterior, inferior, and stuff like that. This is something different. This CMD is the tiny little vessel. So you're looking at like tree roots or branches in a tree. And so as they branch and break off and get smaller, that's different. And that's the same thing with that syndrome. So now we can go here. And this is what we're looking for. So therefore, we wanted to look for, what did she say? She said posterior. And posterior, you're not going to find what you're looking for. So we start here with acute MI. And this is why it's important we know. Anterior wall gives us 3 choices: left main, anterior descending, or another vessel. Okay. Then it says we can do inferior wall. We only have 2 choices: right coronary or other anterior artery of inferior wall. Then we get into other sites, and it says left circumflex. That circumflex, I see that a lot, involving other sites. And then it goes into unspecified site, non-STEMI, unspecified. Now, therefore, posterior, where's the posterior at? Well, look, it doesn't give us a choice. You have an anterior, inferior, other. So what's it going to be? Other. And if it's not the circumflex, it's this one right here. So that's very important. That was a great question, Sandra. And they have names for all of those locations, will be listed. So you're limited to these choices. That's all. But they're not. So they're going to document high specificity, and you may or may not be able to know them, but you need to know what's anterior, what vessels are in the anterior, because if it's not the main or the left anterior descending, then it's going to be, if it's in the anterior wall, then that's our choice, 09. If it's the inferior wall, it's either the right coronary artery or 0.19. And if it's other sites, we have 2 choices: the circumflex, the left circumflex, or right here. So that's, again, very important to understand. I'm going to move this back over here, and it's going to mean that you're not going to see my screen anymore. I'm looking at your questions. So again, 3 great choices. Common mistakes that are made are going to be assuming the diagnosis, assuming that it's a STEMI or a non-STEMI, or not paying attention that a STEMI went to a you see a non-STEMI and you stop in the documentation and you just grab non-STEMI, but then you read and it converted to a STEMI. Or but if it ever says STEMI anywhere in the documentation, that's what you code. Remember, because a STEMI trumps a non-STEMI. So don't code the wrong one. Don't code a syndrome or something else. The location, we're limited. The documentation is going to name all of those vessels, but we have to know, is that going to be, like you said, posterior? Well, then that's going to solve it for us, because we're really limited. Is it going to be, is it going to be above the heart, below the heart, front, back, things like that. Don't fall down. Don't fall under that ACS, acute coronary syndrome, or make a mistake and say chronic MI versus the acute MI or old MI. Now, that correlation of the imaging, and that ticker tape is called imaging, that is absolutely going to be important. That's your golden thread that says how they identified a STEMI and a non-STEMI. And then that 4 weeks. It's that magic 4-week window. Doesn't matter where the patient's at or who's seeing them. If they mention that the patient had an acute MI within that 4-week period or an MI, it's considered an acute MI. Wrapping it all up, what we need to take away is always look at the documentation. Do not jump to the conclusions. Do not speed read, especially if cardiology is not something you're comfortable with yet, because the patient, lots of factors involved, but the takeaways are, if it says STEMI, it's always a STEMI regardless. If it says non-STEMI, then you look and see if it ever says STEMI. Look at the troponin. If it's elevated troponin documented, then you know it's a STEMI or non-STEMI, not something else. Now, we don't code troponin and everything, but that's a red flag. And then so is the EKG or ECG. The sequencing. What is the sequencing for an acute MI? That's always the principal diagnosis on an encounter. You can't get much worse than that. And then the holistic review, meaning you're looking at everything in the notes. You're looking at the imaging, you're looking at the lab value and the provider's notes to understand what type of an MI it is. And then proactive query, if you don't know, if the notes aren't in there properly, then you ask, and there's a proper way to query. That is a reason you might be querying is if multiple vessels are involved and the patient, let's say you're doing outpatient, but it's subsequent hospital visits and stuff like that, and the patient has had a quadruple bypass. Well, chances are we're looking at more than one vessel, so you could have more than one of those codes. And then make sure you understand the difference between a STEMI and a non-STEMI. That's really pretty basic. A STEMI, you're completely blocked off, no blood's getting through. A non-STEMI is a partial blockage. So think, the N stands for not fully blocked, or whatever it takes for you to remember that component of it. And we're at the end.
I'm going to share mine. I want to do a little commercial break here. And then I did create, if you want to refresh your deck, 3 questions that we could do some practice with. I didn't get to fully vet it, so you can help us, not to put you on the spot there, Alicia.
Is that so? That the commercial slides?
Yeah, if you guys want to stay after the commercial break, I created 3 slides while Alicia was presenting with using AI to test our knowledge on the presentation that was just made. So we'll see what we learned here, what we retained. But I want to do a little commercial break here. So we had already had someone asking, how do you get the slides or the tables that were presented? If you're a club member, you can get the handouts. Otherwise, you can rewatch the video either on YouTube, or if you're a club member, you can take screenshots from there. But if you want the nice PDF version of the handouts, we have a replay club that comes with CEUs as well. So just go to cco.us/club to join the club if you're not a member already. And if you are, thank you very much. And we have 3 pricing structures. It's either monthly for $24.99 or annual for $249. So basically you get 2 months for free if you go the annual route. And then we have a CCO Club Plus. So that's for people who are taking courses with us and want to be a club member. And with that, you get 2 courses that you can take at the same time. So maybe you want to do medical terminology and the physician-based coding course, or you want to do pathophysiology and the risk adjustment course. So that one's $329 to get started, and then $99 a month. You can cancel anytime. So that's our club. And we're very excited. We have a clinical documentation improvement, or actually we like to say integrity, CDI. It's kind of used both ways, but the clinical documentation improvement was the original way, and then they kind of started to use integrity. We have been creating our own textbook, our own slide decks, and Alicia is going to be doing recordings on Friday. So hopefully she'll get a couple done this Friday, and we'll get them up. So we haven't even officially launched. We thought we would be ready February 1st, but thanks to our founding members, I think that's our next slide, we had opened up 50 slots for founding students for this course to help fund us to get it created. And well, when this was done yesterday, we had 10 spots left. Now we have 8. So there's 8 more spots left where you can get it at half price, $362. We will never have a sale that will come close to that level of discount. So if you want to be one of the 8 remaining people, go to the website. I'll put that link in.
Well, she's doing that, guys. If you think I like teaching about STEMIs and non-STEMIs and the anatomy of the heart, I love CDI even more. So I'm excited. If you want to learn from somebody that's passionate about CDI and it really, really enjoys it, then absolutely, this is your opportunity.
All right, I put that link in there. Yeah, and we're just loving it. We're just creating slides now with all, the AI technology. They just look gorgeous. And Alicia was like, I can't wait to record this.
No, I told William that. It's like, oh wow, these are just fabulous content. It's going to be fun.
We have our new pricing that we actually started it in September, but it was our 2026 new pricing plan. I'll just give the highlight because I pretty much say this every webinar, but we now, you can be a full pay student, which means you get the whole package, you get the course, you get the blitz, you get the review, the practice exams, you get phone support, and you get it for lifetime now when you become what we're calling a lifetime purchaser of a course. Now, for those that maybe can't afford that, we also have a subscription model. So it's kind of like if you can't own it, you can rent it. And it's $59 a month. You can cancel anytime. This is great if you're not sure if you're going to like our style, although you just have to look at the YouTube videos and you can see exactly how we teach. But it's a $59 investment. You can cancel if you don't like it. So it's a nice try before you buy, and you can always decide to do the lifetime purchase after trying it for a little while. This is also good for people that have enrolled somewhere else and they're not happy and they can't get out of it and they wish they had, joined with us. You could do a couple of months at $59 to supplement our lectures with the course that you signed up for. And also you get our support. You get us helping you. Every student gets a private support room that has me, Alicia, the other coaches, Sylvia, all the help desk, help that you need. And you have one spot, and that's your room with all of us. And we're normally pretty responsive within, 6 to 12 hours. So that is one of the big complaints out in the industry, is that the support is not good. That's what we excel at. That's why it's our middle name, Certification Coaching Organization. We have a YouTube channel. We've been doing this since, I think, 2012, the YouTube channel. So we have lots of videos there. And we do these webinars every Thursday. So for those that said this was your first time, welcome. The one that we're doing right now is the Q&A, second Thursday of the month. Next week is going to be our student Zoom call. That's the third Thursday of the month. That's just for our students and club members. And it's very face-to-face. So it's not just me and Alicia. We're all in like a Zoom room where, you don't have to turn your camera on, but we like it. We normally get, a handful of students, and they get a lot of our attention. And it's very tailored to whatever that person is asking. And then the last Thursday of the month is our club webinar. That's the one that we normally always have CEUs attached to it. So we do open all of our webinars up, not the student call, but all the webinars, 3 a month, to the public. Everyone can watch and learn for free. We've done that for a long time. But if you want CEUs, handouts, and extras, please become a club member and support us. We really appreciate that. So I think that's it for our commercial break. So if anyone wants to drop off, feel free. But if you want to do 3 more questions, I'm going to pull them up, and maybe Alicia can help us with this. Let's see. I'm going to share this tab instead.
I can see it, and it looks, I already looked at them. They look really good. Okay,
good. So, and this is what we teach our interns, by the way. If anyone wants to be an intern, they help create these slide decks that we're doing, and they're learning how to use AI to do it and vet AI, because I'm going to do a webinar on that, because I've learned so much about it and, using it in our industry, in our domain of medical coding and billing. And it does make mistakes, and even with anatomy pictures and labeling. And so we have to be careful. So interns are better than AI. That's what we have to understand. We are better than AI. AI is faster than what we can do, but it always will need the human to vet and verify. So don't just trust it because it's a computer and it looks good and makes it nice bullet format. So that's my little.
It could also come out all in Italian.
Okay, so this question or scenario was: the patient has severe persistent chest pain. The ECG findings are ST segment elevation in anterior leads, and the provider documented an acute anterior wall STEMI. And if I had a quarter for every time Alicia said STEMI tonight, I would be very rich. So here's your 4 choices. And you put in the chat what you think it is. So A would be I2 1.3, which is ST elevation myocardial infarction of unspecified site, or B, I2 1.09, ST elevation of myocardial infarction involving other coronary artery of anterior wall, C, I2 1.4, which is a non-STEMI myocardial infarction, or D, I2 1.01, which is a STEMI involving left main coronary artery. So what to say?
While you're doing that, guys, I want to tell you, if you're testing, the first thing that you should look at is what I told you. A STEMI is always a STEMI. It will never revert back to a non-STEMI. So C is automatically out, right? So you can mark that off. Now you only have to pick through 3.
I'm going to let you tell us what the correct answer is. And I think the AI got it wrong.
Oh, did the AI pick it? Did it do it?
The AI said it was, well, are we done? The AI said it was I2 1.4.
Well, no, that would be wrong.
See, good case in point.
Because once a STEMI, always a STEMI. And that's why now with this is like a perfect test scenario. However, in real life, the documentation will be going through and telling you what's happened throughout the presentations and stuff. So you'll see all kinds of different documentation. But yeah, it would be the what is it? It was the anterior wall.
Yeah.
So it's B.
Yeah, very good. I think everyone got that.
Yeah.
Good job. All right. We got one more. I think 1 or 2 more. Okay. So this one is patient presentation with chest pain. This is no ST, no STEMI, and it has ST depression. The lab results for elevated troponin, and the provider documented acute non-STEMI. What is the correct ICD-CM code? So A, I2 1.9, B, I2 4.9, C, I2 1.4, or D, I 20.0.
So while you guys are thinking this through, again, we can rule out one right away because it says that the documentation gives us a specific diagnosis, not that unstable angina or angina is unspecific. It's very specific. However, we have a diagnosis and it doesn't match D. So D gets ruled out. And the other thing that you have to look at is that we read our charts usually upside down. So we start at the bottom with the diagnosis and then verify, working our way up to the HPI. So we know it's acute, which all of these are acute. So next it says non-STEMI. So if it says non-STEMI, we need to know, was it ever a STEMI? And it wasn't, right? So that rules out A and B. So this is a non-STEMI I21.4. Now,
Answer C. Yeah.
But keep in mind also, guys, the labs, we have the if you're doing like risk adjustment, you have the validation of this ECG and the troponin, the lab work. So that tells you the person did have a heart attack, not unstable angina, because the troponin won't be elevated if they have angina or angina.
By the way, I have to apologize. The AI did get the last one right. I was reading the answer for this one.
Oh, I didn't pay attention. Okay.
All right, one more. Last but not least. So this patient presentation is chest pain, non-STEMI, and lab results. Is this the same as the last one? Sure does feel like it, doesn't it? Elevated troponin and acute non-STEMI. Is this the same? No, it's a little different. So is it A, I21.9, B, I24.9, C, I21.4, or D, I20.0?
I know you guys are going to get this, but what I want to know is, did you recognize what was different in this one than the previous one? So they're both non-STEMIs. We got that. But what's the difference? So yeah.
One.
So there is no location in a non-STEMI. I mean, there's a location, but non-STEMI, we can't code for location with non-STEMIs. So all non-STEMIs are going to be I21.4. That's kind of what I wanted to bring to your attention. So if it's non-STEMI, we're lucky. We got one choice only. Or was there two? No, I think there's one or two choices. But with the STEMIs, we got to identify the location and the vessel.
Perfect. So the answer was C.
You guys
good job, everyone. All right. Well, that was pretty good. I like that.
I like how this lets you practice and rule out now, mind you, Lorraine made these really quickly, and it did a beautiful job. When we have more time, we can tell it what we want it to do. So we can put more complexity in there. And that's what we do to give you the best practice. And then our real world background, the scenarios that we know you'll be tested on, as well as what's going to cross your desk. So I think that that's something to appreciate and the value that we offer to you. Plus it's fun.
And I wanted to share something with the group because I'm just getting more and more excited about this. We've adopted this platform that I'm showing here. This is our new course delivery area and our community area. It's built on a platform called Circle, and we have the highest end one, and it comes with AI agents that we have trained on all of the content in the academy. We have 2 AI agents, one for help desk stuff, and then one for the entire content. of all of our courses, every single transcript, any handout, all of our webinars that go into the club replay. And it's only using our content. It's not going out to the web and possibly finding someone's blog article where they might have some misinformation in there. It's just using our stuff. And lots of times students will ask a question and I'll go ask we call it CodyBot. And there's a couple ways to access it. But basically, if we go to the search in this upper right-hand corner, I can start to type in. Let me grab one of my questions that we just did tonight. And if I paste that in here, because I'm a premium member, right, I can ask the Cody Premium bot. If you're a free member, you can only ask the Ava bot, and she's only trained on the help desk stuff. So we're going to ask Cody Premium bot. Let's see how he does. I have no idea how he's going to do. Or I don't know. Is Cody a he or she?
It could be either one.
That's right. It's an it. Okay. So CodyBot said, can you see this? Is it big enough? For a patient with an acute anterior wall STEMI, did it get it right? Uh-oh. Make me a liar. No, I did get it right. I21.09. This code is used for STEMI, myocardial infarction involving other coronary artery of anterior wall. It's important to ensure that the documentation specifies the location. So it got it right. And it gives you the sources where it got it from. So it found answers to this in the ICD-10 Blitz, Module 5, in our Intro to ICD-10 Coding, Module 5, and Module 16, Diseases of the Circulatory System. I think that's our PBC course, or maybe our ICD-10 course. I don't know, but it just goes to show this is really powerful, guys. I mean, you can ask Cody, I think these are all ones that I was just testing. Someone asked this today about they just finished Module 4 of the PBC, and they didn't understand about residual sequela and late effects. So then I just said, well, I could go look it up and try and type up an answer. So I said, let me see how CodyBot does. Perfect. Good answer. I copied and pasted it. So it's basically like you get access to your coaches with this, and you can ask at midnight. You can ask it 100 questions. It doesn't get tired. And, you know, I'm not saying that it's 100% accurate, but so far it's been doing way beyond how well I thought it would do. So, I mean, this is just phenomenal. Let me see some other ones. So I asked it, this is what I coach when I do the welcome calls. I said, remember with CodyBot, before you go to take your end of chapter exam, ask Cody to test your knowledge on your understanding of the topic, because Cody has access to the lecture and all the handouts, all that stuff. So I said, hey, Cody, I just finished chapter 5 of the risk adjustment course. Can you test my knowledge before I take my chapter exam? So at first it's like, well, I can help guide you. Well, with AI, and this is true for all AI, not just ours, you got to give it more context. So then I said, please ask me a review question I can try to answer. So now it gave me the question. Well, then I said, may you present it in a multiple choice format, please? Then it got exactly what I wanted. So the more context you give it, please help me review this chapter by giving me multiple choice, questions that I can answer. So now it gave me this, what is the significance of specificity and risk adjustment coding, and how does it impact the calculation of a patient's risk adjustment factor, RAF? And it gave me A, B, C, D, and I said B, and he said correct. And then I could say, may I have another, please? So this is a phenomenal tool that you get as a student, whether you're a subscription student, the rent, or you own the course. And as long as you're a premium member, you get access to CodyBot. You can use it for work questions. So if you're stuck and you're trying to code, a report, see if CodyBot can help you. Again, you always need to, vet and verify, but it's a great tool. So I just thought I would share that, because I just think that is definitely one of the things, plus our support, that that makes us a good choice if you're looking to take a course related to medical billing and coding. So let's see, Sarah said, I used Cody when I needed help with a work encounter a few days ago. Did it help you?
Yeah, that's the question. Did it help?
Yeah, but thanks for sharing that. Yeah, and I tell people and they forget. So by me using Cody, it's not because I'm trying to be lazy, but I'm trying to, again, teach the students how to fish. Do it, and then you don't have to wait for me or Alicia to answer. And now maybe it doesn't quite get exactly what you wanted. Keep clarifying, keep asking. You don't have to just get it right in your first prompt. And we can see with our inbox how the students are interacting with it, and my mind is blown. Some of these students are like having a relationship with Cody, let me tell you. And they talk to it like, oh, thanks, that's really cool, I didn't understand it that way. Or maybe you've just listened to a lecture and you're like, I'm a little confused, or some people like to say, I have doubts on, whatever subtopic. Could you reteach it to me? And it will reteach it. So now you've had maybe Alicia's way of teaching you, Laureen's way of teaching you, and now you've got the CodyBot way. One of us is going to resonate with you. It doesn't mean that someone's not a good teacher, but for whatever reason, you didn't get it. It didn't stick.
Or one part.
Right.
So you say, hey, okay, I know non-STEMI and STEMI, but I just don't understand what unstable angina is compared to other types or something. And then boom, it'll break that down for you.
Yep. And then another thing, I was just speaking to a dermatology group, and they're going to be enrolling 3 people from their group, and the work-related questions. And they have a EHR that comes with a coding tool that suggests the codes. And if it doesn't seem right, ask us, say, hey, this is what we're being, this is the code that our EHR is suggesting, but we're thinking it should be this. What say you? And Alicia and I, or the community, could weigh in on it. That's a benefit of the club. We will help do that. We just don't code it for you. So you don't want to give us a redacted report and say, what are the codes for this? We're not going to do that. But if you say, I think it's this, or my provider said this, or now the EHR is suggesting this, we can help weigh in and give you rationale why, and help you to reason, and help you to understand how to get to that answer. So that's another perk of club membership. So again, $24.99 a month or $249 annual. I will say for the annual club members, you get an extra benefit as well. If you've ever purchased a course that is expired with us, you can get your access restored to it as an annual club member, not a monthly, but an annual club member.
Which is a huge perk.
Yeah. So that's all I have. Did you have any last minute stuff, or were there any last minute questions?
I'm not seeing any other questions come through, but I do want to remind everybody that if this was helpful to you, make sure you tell your peers and your friends, or if there's anybody just thinking that they would like a career in medicine and have talked about this, absolutely pass our name on, because we don't advertise. We're word of mouth. And so we rely heavily on you, the hidden little gem that CCO is, to pass the word, share on your social media and LinkedIn and stuff like that. And your coworkers, your peers.
So Tatiana, one of our interns, she said, I worked Cody overtime the other night with a Practicode question. It's a great resource. Working with AI really can be wonky. It makes silly mistakes, but because Cody is connected to their database, more often than not, it does have a fairly accurate answers. I noticed some inaccuracies, but usually only due to code needing to be updated in the source it came from. So just vet with your current books. Yep, very good.
That's good advice.
Yes.
I know that I've had other Practicode still. I don't know if they've given it the love that it needs, but yeah, you can absolutely defend your answers or your thought process by doing that.
Yeah. And then as far as the CEUs, when you're in the academy, Let me share that one more time here. The way you get to like the recordings of all of our webinars and everything as a club member, on the left-hand side is how you access all that, they call it spaces, whether it's a course space, a blitz space, or a discussion space. So you would come here to club replays. And when you come in, you're going to, I got to change this as an admin. Okay. And you'll see all the CEUs. I'm going to make this a little smaller so it fits. So here's this last one. It lets you know that there's one CEU available and it expires November of 2026. So you would just click on that and you could rewatch it right in here. You can also click this little chat bubble and ask questions on the content, and Alicia and I will see that. You can see a summary. This is where you get the handouts. And you get all of the timestamps. It's very, very detailed. Oh, I don't think this is what I was trying to show you. So this is what the transcript looks like. And if you just want the slide handouts, it'll look very similar to what you saw tonight, but this is a PDF version. So for all the people that were looking for, you know, the tables and stuff like that, it's all in the club. And this is where you would click on to go take your CEU quiz. Now, our CEU quiz does open up in our previous, what we call our legacy one. And, you know, you'll have to log in. Oops. I think I just changed this. There we go. And you'll see there's 10 questions. You click start. And when you answer the 10 questions, you will be presented with a CEU certificate with the AAPC logo and the index number and all that good stuff. Okay. It does take a bit to load, but yeah, so that's where you go find the CEUs, but you have to be a club member. You know, in the past, we used to do it differently. This is how we're doing it because administratively, it was just becoming a nightmare. So only club members get CEUs. We do have a few free CEUs that were sponsored by Find a Code, and you get to them the same way. Instead of going to the CCO club replays, they're actually in here. But if you're a free member, you come here and free CEU is what you want to click on. And you'll see in here there are 2.
Althea says that she thinks the July webinar might be missing. I don't know. We'll track that for you.
Yeah, Mary's working on that, so she got your message. But yeah, so these are the 2 free CEUs that were related to the 2026 ICD and CPT updates. So every year we'll be doing that, and thanks to Find a Code for sponsoring that. And if you know of anybody, or if you are representing a company and you'd like to sponsor CEUs, let us know, because AAPC charges way too much, $330 for one CEU.
Right.
So, all right. Well, thanks, everyone. Thanks for your attention. Thank you, Alicia. Great job. And we'll see you soon.
It's Thursday.
Yeah, for our student one. Bye, everyone.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.